talking about cardiomyopathy. Does anybody know anybody with cardiomyopathy? No? All right, cool. What are they about to find out? All right, so here's a quick overview of the heart. All right, so it's like one of the hardest working muscles in the body, right? Beats over 100,000 times a minute on average, and I'm assuming that's at rest. It's about the size of your fist for the average person, all right? And it's a two-sided pump, all right? One is low pressure, the other is high pressure. Who can tell me which one is which? Right side.
Low.
Right side low pressure, left side high.
All right, cool. So let's go ahead with a little bit of recap, all right? So beginning with the vena cava, where's the blood gonna flow next? Good job, Jordan. What's next? Come on, y'all, we just started.
Tricuspid, then the ventricle.
What's next?
No.
Right atrium? Right ventricle?
Right atrium.
All right, cool.
Bicuspid.
Via the bicuspid valve, all right? So we down here now. There we go. We're down here now, all right? So from the bicuspid valve, we're going where? To the right ventricle, and then going into pulmonary circulation once you pass the pulmonary semilunar valve right there.
Try before you buy it, right?
Yes.
There you
Tricuspid
go.
before you.
Tricuspid, thank you for that. So y'all are paying attention. That's good. All right, so actually we're talking the right side of the heart. So yeah, you're right. That's the tricuspid valve. My bad. So after you go through your pulmonary arteries, you're gonna continue to the pulmonary veins. All right. At this point, pulmonary circulation, you got the exchange. You know what I mean, between your deoxygenated blood, which is pretty much picking up oxygen up in the lungs. All right. Your oxygenated blood in the pulmonary veins is gonna return where?
Left atrium.
All right, cool. The left atrium, and then past the mitral bicuspid. There you go. And then you're going into the left ventricle right here. From there, right back to the body via the aortic valve right there, semilunar valve, and then you have the aorta to the rest of the body. Good job, everybody. All right. So we got like 4 properties of the cardiocytes and everything. All right. So automaticity, meaning it does not need any, message from the brain in order to beat. Okay. Contractility, these muscles are able to contract, okay, on their own. Excitability, the ability to conduct those nerve pulses in order for it to beat. And then you have conductivity. It can take that impulse in order to do what it needs to do. All right. So as you can tell, right here we have a little heart. Nobody's heart is that shiny. I don't think. All of y'all are demons. I'm kidding. All right, moving on to the next one. So we have a heart transected right here. We've seen plenty of these already. Some of you guys, all of us did the little pig heart. Let's start with some labeling now. Who can tell me what A is?
Septum.
All right, cool. That's your septum. What about B? It's on that wall, it looks like.
The myocardium.
Right ventricle, myocardium of the right ventricle. That's cool. C over here. This is the left side of the heart. Talking about the left wall, right? Left ventricle, myocardium. All right. We have, looks like these muscles right here. It's D. What's that? Say again. Papillary muscles. All right, cool. And then E is on the strings.
Chordae tendinate.
Chordae tendinate. Awesome. All right, cool beans. Good job, everybody. So that's a little overview of the heart. Now we're going to talk about cardiomyopathy. So there are various forms of it. It's not just one, disease. There's also many, different pathophysiologies. All of them kind of share that. But when we really think about cardiomyopathy, just like the term heart failure is an umbrella, cardiomyopathy is another umbrella that's under, heart failure. In the heart failure family, I'll say that. All right, so we're going to talk about types of cardiomyopathy and the different morphologies of the heart. We're going to talk about the pathophysiology, causes, etiology, things like that, signs, symptoms, associated with each kind, and then definitive treatments, which for the most part is going to remain the same for all of these. Okay. So what is cardiomyopathy? It's a family of conditions involving ventricular deficits, and basically it affects the cardiac outflow and everything. All right. So also the heart's ability to pump blood throughout the body. You know, the heart is a container. Your vessels are your vessels. You know, they carry that. Actually, the heart is the pump. The vessels would be the container. You know, so you got structural and electrical deficits. So when you have heart wall that isn't quite normal, all of the cells aren't the same cell, which should be cardiac. You know what I mean? If you have tissue that is overstretched, tissue that is scarred, that's going to affect how the heart is going to beat. And also how much blood can be pumped out through the body. So ultimately progresses to heart failure, AMI, or death in worst cases. All right? And there's that source there. All right, so the cardio effects. All right, so with cardiomyopathy, 1 in 500 adults are diagnosed with cardiomyopathy. The disease is more prevalent. I'll say this. In the studies that they did, it showed that African Americans are at higher risk than white Americans. And then it's going to affect males so more than women because, you know, guys tend to, you know, we just live harder, I guess. You know what I mean?
Now, guys are more apt to say, I don't need that medicine.
Yeah, there's that too, you know. But there's going to be more on that later when we talk about athletes and whatnot. All right. So one thing I can't fail to mention before going forward is ejection fraction. That's one thing that's going to be severely impacted while you know, these tissues are undergoing their changes and everything. So your ejection fraction is the amount of blood pumped out of the ventricle divided by the total amount of blood in the ventricle. All right. So normal range between 50 and 70% of the heart. Ejection fraction. All right. You got to have some blood left over. I don't think a completely empty ventricle would benefit us. Heart failure and cardiomyopathy, once you go below 40%, that's where, you know, you go and see your doc, they'll probably diagnose you for that. And then once you have over 75% of that blood ejected, you know, because your heart muscle is just so strong that, you know, just pumps nearly all of the blood out, that's where they consider you hypertrophic. We'll talk more about that later. So we got typical symptoms here. Now, depending on, you know, the person's age, you know, who they are, they may be asymptomatic for a long time. I mean, weeks, sometimes years even. You got your orthopnea, edema for sure, depending on which side of the heart. It could be systemic, pulmonary, or both, if both of the ventricles are failing. Then you have angina for your patients who don't have a heart transplant. And then shortness of breath. That's not son of a bitch. All right, so etiology for cardiomyopathy. Some forms you can only, you know, they can only be passed down genetically. You also have, you know, that's to include gene mutations and things like that. And then it can also become acquired from your environmental factors, things like stress, things like, you know, your lifestyle, etc. And then you have complications due to infection, things such as, you know, pericarditis, myocarditis. We'll talk about that later too. All right, cool. So there are more than 3 types, but because the primary 3 types that I guess people study are here, I just got them all on one page. Shout out to Khan Academy for putting all these here. So a dilated cardiomyopathy, you basically just have the heart muscles, the left ventricular especially, it's just like overstretched, right? So Starling's law would, you know, apply that, you know, the more stretch you have, the higher the contraction. But this thing is stretched out so far, you know what I mean, that normally the white lines here would be, you know, the normal, I guess, ejection fraction, how much that heart is going to squeeze, you know, but these things are stretched out so much that, you know, it's not going to pump out a lot of blood. So you have a lot of blood still left in the ventricle. pretty much what this is a stretched out, weak, very thin ventricular wall there at the apex. We go to the second one, we got a pump that is pretty much, it's not gonna give. You know, there may be some mineral deposits in that cardiac tissue. There may be iron, you know, that's a mineral, excuse me. There may be other things that could be impeding that. Scar tissue, maybe they had cancer treatment or something like that, and, you know, maybe they've done drugs that's, you know, pretty much damaging the tissue of the heart. All right, so this orange here just represents that scar tissue that will not give. When there's blood going into that, you know, it's not dilating and it's not gonna contract during systole. So there's a rigid wall with restricted cardiomyopathy, and then a third type is hypertrophic cardiomyopathy. So a lot of athletes, you guys ever heard of sudden death, sudden cardiac death? Athletes you hear about, they just drop dead. I don't get it, he was healthy, she was healthy. You know, so what's happening is they probably could have gotten it from maybe a lot of exercise, strenuous training and stuff like that. So they'll have heart problems. And some of them could have like some genetic problems or whatever. They could be doing drugs. They could have all three factors going on at the same time. So what happens is you have an enlarged septum right here. You know, that heart muscle just thickens, you know. If there's any muscle that you don't want to get thicker, harder while you're working, that's gonna be the heart. Because the thicker this wall gets, the thicker this left ventricle gets, plus the septum, they're squeezing in on each other, the less volume you'll have to fill, right? And then when this thing contracts, you know, you're just pushing out a tiny little bit of blood, but you're like overdoing it. So that's those three, but we also have two more that I'll talk about. That's arrhythmogenic cardiomyopathy and Takotsubo. We'll talk about that later. So begin with dilated cardiomyopathy. You have the left ventricle enlargement. So we have a normal heart sitting over here on the left, excuse me, the right, and then on the left side you have your dilated left ventricle there. So there's not really much muscle in that chamber as there is for a normal one. You know, it looks like there's so much space, but it's not going to contract well. All right, so you have decreased contractility, therefore decreased stroke volume and everything else after that. You know, that affects how nutrients are delivered to the body, to the brain. You know, you need your nutrients and everything. All right, so we have different causes here. All right, I think, if I remember correctly, I think coronary artery disease is probably one of the key factors when it comes to that. You know, it's just putting excess pressure, you know, on the heart and whatnot. So of course you have your nutritional deficiencies, you have hypertension. Now, personally, I believe that it's going to be prolonged hypertension. If it's just hypertension from drinking coffee, you know, that one time of the week that you do drink it, you know, because you got an upcoming test, I don't think that's going to contribute to that. I believe, you know, from what I read, prolonged hypertension. And in pregnancy, there are some cardiomyopathies that develop as, you know, not as a result of pregnancy, but probably just, you know, some complications maybe. Certain infections, you know, pericarditis, anything dealing with the heart, maybe some valve, you know, infiltration by some bacteria or something like that. Alcohol, cocaine use, you know, anything that pretty much damages the heart could contribute to that. I said heart valve already. And then autoimmune, you know, you might have something that attacks the cells and they decide to go after the cells of your heart. Signs and symptoms, this is pretty much, we're pretty much gonna see some of these signs and symptoms throughout the rest of the PowerPoint, just so you know. Heart failure, because it is a heart failure disease. Right ventricle enlargement, possibly, usually the left will precede that. You have cardiomegaly, can anybody tell me what that is?
Enlarging of the heart muscles.
Right, I mean, whenever you see megaly, that just means enlargement, all right? So just the giant size heart might be, you know, as big as a basketball instead of bigger, as the size of your fist, excuse me. Increased jugular vein pressure, you have edema, all right? If it's the left side, it may be pulmonary edema. The right side is definitely gonna be in the extremities. And then, of course, angina, you know, and that's probably because of the ischemia and whatnot. All right, so that's the cadaveric view right there. So as you can see, you have a pretty normal looking right ventricle, besides the fact that the size of this left ventricle is impacted. You know, that's really not a lot of myocardium there for a good contraction. It's not supposed to be that large, that ventricle. All right, so diagnosing it, that's not what we do. I mean, we don't really diagnose. We can say, okay, maybe based on general impression of the patient, you know, they may show signs of, but they're gonna need to go to the hospital for some definitive, you know, answers. All right, so we look at this echocardiogram here. You can see the enlargement of the left ventricle compared to the entire heart. That's like 75% of that heart right there. Big problem. All right, they may use a cardiac MRI, take it to the cath lab, and then of course, you know, you have your biopsies for a way to determine, you know, what went on with that person. So for management, that person can of course comply with, you know, a low salt, low sugar diet, you know, manage, you know, fluids and stuff like that. Excuse me. Sugar, anytime we consume sugar, we're basically putting inflammation. We're creating a good environment for inflammation and whatnot. So there's that, and then you also have your medical, your medicine compliance as well, treatment compliance. All right. And then we go into pharmacologic that they may do at the hospital. You know, we can probably look at these things too. So you got your diuretics, such as your ACE inhibitors, which can decrease, you know, the abnormal fluid balance and whatnot. You also have your beta blockers, your calcium channel blockers, to decrease that myocardial O2 demand. Could address some of that angina there, and of course any dysrhythmias that come with that, we can manage that as well. Digoxin has an inotropic effect, so that could be used to address some arrhythmias as well. All right, moving forward to the second type, we got hypertrophic cardiomyopathy, okay? So, we got a normal heart sitting over here, and then we have that hypertrophic left ventricular wall there. I mean, there's really like no chamber room at all. That's like a teaspoon of blood probably you can fit in there. You know, you're not gonna get much delivery to the tissues. So, it's an enlargement of the structures I just talked about. This is more of an obstructive form of it, right? So you have your septum and your left ventricular wall squeezing together. The heart, like, it's pretty much like working against itself for that contraction. So you have, you know, causes, or I'll say it's highly associated with genetic mutation of some of those genes that affect, you know, how the heart muscles lay out. Of course, hypertension can play a big role in that. Your blood pressure is super high, the heart has to work harder, you know, in order to get that blood there. In return, your heart says this, meanwhile you're walking around, you know, dealing with those symptoms. All right, so there you go. Most frequent cause, I'll say that again, the most frequent cause of sudden death in young athletes, young, highly trained athletes, all right? And it affects 1 in 500 people, according to Merritt, all right? Signs and symptoms associated with it is, you know, you can take your stethoscope on the apical, the apex of the heart. You might hear a murmur. That's that turbulent blood, you know, rushing through the heart and everything. So you can hear it rushing against those structures. And then your S4 sound, that's an extra heart sound that we don't want to hear, along with S3, which, you know, we'll talk about that later. I believe that's one of the other ones. Some are asymptomatic for years. Man, in fact, I remember we had a guy in my middle school. I never knew the guy, but played football, and they had practice, and the rest of the day we were mourning because, you know, this guy dropped dead, you know. So, you know, it said something was wrong with his heart. Looking back all these years later with this knowledge, you know, oh, that's probably what happened to him. All right, so you got some ECG changes, left ventricular hypertrophy, and 95% of patients with hypertrophic cardiomyopathy are gonna show that, you know, so that may have a strong hint that they have some cardiomyopathy going there. And it's also associated with Wolff Parkinson White. I didn't go too deep into that, just for, you know, the sake of, you know, invoking your curiosity so that you could. So management, beta blockers, calcium channel blockers, to manage that high heart rate, which will allow the heart to fill up, you know, in an adequate way. And also to address any arrhythmias. You have, you know, septal reduction treatments. They may do surgery on that heart. I read somewhere that they inject like alcohol, some kind of alcohol substance that will either shrink those cells or just change their metabolism so that they aren't growing, you know, as it's beating throughout the day. All right, so that's your cadaver there. You have a regular strong, man, that looks too fresh to be a cadaver. Anyway, you got a normal heart over here, and then you have this basic, I don't know, you can't really call that a heart. It's just a block of muscle. This thing is swollen so bad that, you know, the right ventricle is just, yeah, man, it's crazy.
Imagine that ejection fraction like maybe 19%.
Yeah, look at that. What are you gonna deliver to the body? Still got 5 or 6 liters, you know what I mean?
And if that person codes doing CPR, that's even less that you get.
Yeah. Yeah. Bad.
Good point.
All right. So that's 2 types that we just covered. Now we're gonna go ahead and move on to restrictive cardiomyopathy. Couldn't really find any good cadavers, you know, so you got a little illustration here, a regular heart, what looks like a regular heart. And then we have heart over here with some, you know, scar tissue there. But this one here is very similar to the hypertrophic cardiomyopathy in many ways, but I'll let my slides do the talking. So this occurs when the ventricle hardens, again, as a result of fibrotic scarring from any medications or any treatments that you're undergoing, or even natural means, or unnatural drug-facilitated means, if you know what I'm saying. Infiltration of certain metabolites, and then you have protein or minerals such as iron that's depositing in this cardiac tissue. And of course, this isn't the same tissue that's, you know, going to be autorhythmic, that's going to conduct electricity, that's, you know, can't contract. It's not living tissue, so of course it's going to affect how the heart is going to work. So I had something down here for that. I'm trying to remember what it was, but I'm gonna just read it. Maybe it'll come back to me. Prevents the heart from dilating. Yeah, there we go. So it's gonna prevent the heart from dilating on diastole and contracting to its best ability on systole. All right. So you get poor ventricular filling, poor cardiac output, and then you have what's called systolic or diastolic failure, or just, you know, just typical signs of heart failure there. You can have both. All right. So management, ACE inhibitors can be used to decrease the arterial resistance, and that's going to have it's also going to have positive inotropic effects, so the heart can, you know, get a stronger contraction, and then it's going to increase that cardiac output to some degree. Hospital management, of course, for, you know, how they can further treat that. For us, you know, I guess we just do our normal thing, stabilize them, and transport. They can use imaging, and this is really important to determine because with restrictive cardiomyopathy, it may look like restrictive pericarditis. Remember, you know, pericarditis is the sac, you know, so that sac becomes hardened, and the heart won't, you know, beat beyond that hardened sac, right? This is the actual heart muscle itself. That sac could be fine. Heck, both of them could be damaged and scarred. So, you know, you need imaging to rule that out. You can't, you know, do that in the field. All right, so now we've got the 4th type. This is arrhythmogenic cardiomyopathy, sometimes called arrhythmogenic right ventricular cardiomyopathy. I just chose the simpler name. So what this is on this picture here, you know, what looks fine, I guess, in comparison to that. So this tissue it's just all ate up And this is an autosomal, gene mutation. So somewhere down the line, the body just attacked those myocardiocytes. And you can see right here, it's just slowly like denigrating. All right. So this is also genetically acquired. Just said it was the autosomal gene mutation. And those myocardiocytes are replaced with fibrofatty tissue. That's not heart tissue. That's all we need to know about it. And so it affects the contractile strength, the conductivity, and everything else that allows our hearts to beat the way they should. Young athletes, again, man, man, this thing just loves young athletes. High sudden risk of death due to, the lack of contractile tissue in the heart. If you're working your body to the point to where, you're demanding oxygen and the heart can't keep up, and then you have no appropriate tissue that can allow that, and you're just gonna drop eventually. Ventricular dysrhythmia is high. ECG changes. You have an epsilon wave. I didn't even know there was a such thing, but go ahead and Google that. Take a look at it. I wouldn't put it in the slide, but sometimes Google be wrong. I'm not gonna be up here putting something up there that I'm not sure of. So you also have T-wave inversions in V1 to V4. All right, so diagnosing it again is gonna take some imaging. Echocardiogram is gonna be everywhere, MRI, etc. All right, Takotsubo cardiomyopathy. Sounds like taco and sumo, so did a thing there. But this here is really interesting because number one, I thought maybe Takotsubo would be the name of the doctor that discovered it, but it was actually named for its shape. I'll get more into it after we talk about why they call it that. So you have a normal heart here, and we're basically looking at the left ventricle, all right? So with Takotsubo, the shape of the left ventricle looks very similar to, I guess, an octopus in an octopus trap, all right? And when we look at it from this picture, it doesn't really look like much. It's like, okay, what is that? But these tissues start folding onto each other, like when they do become symptomatic, and it'll stay there. It's like, the muscle's in shock, but we'll talk about that, all right? So originating or first discovered in Japan, the name is from the Japanese language. Tako means octopus in Japanese. Subo means pot. So you put it together, octopus trap, octopus pot. It's what the Japanese fishers use to catch those little octopi. Yeah. All right. So that's Takotsubo. It's also known, this is probably the more common name for it, broken heart syndrome.
I've heard that before.
Right, that's exactly what this is. All right. So the left ventricle caves into itself during systole following an intense, stressful event. All right, so just imagine, I guess, a piece of paper. When you ball that piece of paper up, it's gonna stay balled, right? Unless you unball it. It's pretty much what's going on with this left ventricle here. All right, so Dr. Komamura states that 90% of patients are going to be postmenopausal women. All right, so that group there is probably, that group is 90% of the patients. The other ones, it was young athletes. We're still talking about a disease that males are, more highly susceptible to. All right, so what happens in a stressful event? You got sympathetic activation by the nervous system. And of course, it's going to cause a cascade of things that are going to happen that can intensify these symptoms and everything. All right. So with sympathetic activation in the body of the nervous system, which releases catecholamines. That's all your stress hormones, cortisol, epinephrine, things like that, norepi, increases vasoconstriction, it increases the heart rate, it's going to increase contractility of the myocardiocytes. The heart is going to be working hard. It's normal until it gets abnormal. All right? So we got signs and symptoms. They're all relative to the stressful events. So you got acute chest pain, and you can probably experience that in any of these. So it's just, you know, keep that in mind. Shortness of breath, dizziness, syncope, because there is more left ventricle involvement than right. And then you have ECG changes, possible troponin elevation if it's that bad. It scares them into having an ACS. Excuse me. And then it's also self-limiting for the most part, so it will resolve in time. And I'm gonna go ahead and mute that. Excuse me. All right. So in the worst case scenario, we got hypotension as a result of that muscle staying contracted, this wrinkled up left ventricle wall. You got thromboses that can occur because, you know, that could possibly hold blood depending on the shape and morphology of that contracted little octopus, you know, in the heart. And then you have left ventricle wall rupture. So just imagine the heart contracting so hard that it just, you know, ruptures. That's gonna, you know, that's bad.
That's the end of it when that happens.
Mhm. So treatment for non-ruptured heart is gonna be management. And if they are symptomatic, then you can follow maybe you can follow the ACS protocol. Definitive treatment at the hospital, diagnosing using cardiac imaging. They're gonna use coronary angiogram. I saw that on TV not too long ago. I thought it was really cool. Blood test for troponin, and then you have your echocardiogram. All right, so we're gonna talk about stress now, how stress is involved, how coronavirus is involved, all of these things, all right? So ACS patients had a higher incidence of stress related to cardiomyopathy during COVID-19 pandemic than any of the previous years so far that this person has been studying, or these people, this group of people, have been studying people, all right? So that really says a lot there. Something as simple as, well, it's not really that simple. Some of us handle pandemics better than others, I'll say. If you have somebody with, let's say, general anxiety disorder, something like that, just imagine how hard this is on their heart, you know? If we can't do so emotionally, you know? It's really, really gonna be hard on their heart because of all the stress and everything else. All right, so we're gonna do a quick summary on heart failure. All right, so systemic circulation backs up as a result of right ventricular failure. And then, you know, you're gonna have that lower extremity, edema, shortness of breath. If they're in the bed, they might even have it like in the sacrum area, so sacral edema. Shortness of breath, which will be a hallmark sign, the high respiratory rate will indicate the shortness of breath. We wanna be careful about medications that can alter preload and afterload in a patient that has right side heart failure or heart failure period, especially the right side. So pulmonary circulation backs up as a result of the left ventricle failure, and then this is when we start seeing the difference in the symptoms: syncope, shortness of breath, fatigue, and rails crackles upon auscultation of the lungs. All right. So let's do a quick recap on cardiomyopathy. All right. So we talked about all of the different types. I'm pretty sure there are many more being discovered, but I picked these 5. All right. And then we went over pathophysiology for all of these, the signs and symptoms, and then we talked about some definitive care diagnosing tools that they'll be using at the hospital. All right, so do we have any questions? Thank y'all for your time.
How's it going to put together paper, son?
I appreciate it.